Greetings. Let me share with you this lecture that I prepared for my fellows who joined us this month about perioperative management of antithrombotics in patients undergoing various gastrointestinal endoscopy procedures. I hope this is useful to you also, and take time to review this disclaimer. So when you see a patient who is scheduled for endoscopy, whether it is upper endoscopy, colonoscopy, ERCP, EUS, and the patient is on antithrombotics, you have to make a couple of decisions. When do you stop the antithrombotic before the procedure, and when do you restart the antithrombotic after the procedure? So basically what it means is it is all about stopping the anticoagulant and restarting the anticoagulant in relation to that particular procedure. The goal for stopping the anticoagulant is to prevent bleeding, and restarting anticoagulant, the goal is to prevent clotting. So these are two opposing events, and how do we manage our patients uh, who are on antithrombotics? In order to understand when do you stop the anticoagulant so that the blood becomes thick enough for the surgeon or the endoscopist to do the procedure safely, and how do you decide that? So for that, it is all about the drug elimination half-life. It is about the duration required for the drug's active concentration to be reduced by exactly half, that is half-life. So say a particular drug has a half-life of 5 hours. If you stop the drug 5 hours before, the drug concentration will drop by 50%. That is one half-life. If you stop the drug 10 hours before, the drug concentration will drop to 25%. So 2 half-lives. And by 3 half-lives, you drop it to 12.5%. Most antithrombotics will reduce to almost acceptable levels for the procedure to be done by about 4 to 5 half-lives. So this is very important to keep in mind. This 4 to 5 half-lives of the drug is what is taken into consideration in planning for that particular procedure, especially about taking that 4 to 5 half-lives and deciding when to stop the medication prior to that endoscopy procedure. And the half-lives for various drugs differ. It's important to keep that thing in mind, and we will talk about the half-lives later. So we talked about taking into consideration the half-life of a drug to decide about when to stop treatment before the endoscopy procedure. So the procedure goes well, and then you have to decide when do you restart the medication. When it comes to restarting, it is all about maximum activity of the drug achieved after you start the medication. So when do you achieve peak therapeutic effect once you restart the drug? So by knowing the peak therapeutic effect, you should be able to figure out what to do in a particular situation. So the goal is to make sure that the procedure goes well. Patient will come out of the procedure without any major bleeding episode by starting the drug so that there is no overlap of the procedure-related bleeding activity and the maximum therapeutic activity of the drug. So by keeping those things separate, you figure out a way to steer the patient out of the procedure without major bleeding risk. So we learned about two important concepts. Let us review them again. Say, for example, here is a patient that is undergoing surgery or endoscopy today. So this patient has been scheduled for today, and he's an antithrombotic medication, and you take the half-life of based on the clearance or the half-life of elimination, you figure out and stop the medication days before the procedure, depending upon the half-life of elimination. The procedure goes well, and you feel that you've achieved hemostasis, and then based on the time to reach peak activity or maximum activity of the drug, you use that time to plan on restarting treatment after the procedure. So these are the two important concepts: half-life of clearance, the clearance mechanism of the drug, and peak activity. If you know these two, you can figure out how to plan a patient's procedure and make sure that the patient comes out without getting into trouble, either with bleeding or with a clotting episode. So now let us use these principles to learn about how do we apply these principles in the management of patients who are on antithrombotics. We know that there are at least 4 different types of antithrombotics: vitamin K antagonists, direct oral anticoagulants, low molecular weight heparin, and unfractionated heparin. And let us look at their half-life of elimination for these different drugs. So it's hard to remember the details, so I made it very simple. Half-life elimination is fast, in 1 hour, half an hour to 1 hour. Then there's another group, 3 to 4 hours. Then there's another group, 9 to 14 hours. And then the last group is 36 to 42 hours. So who has the fastest elimination within 1 hour? That is unfractionated heparin. Next comes low molecular weight heparin in 3 to 4 hours. That's what you use to keep in mind to decide, hey, once you give a low molecular weight heparin, how long do you wait before you schedule a patient for a procedure? You use this elimination half time to decide about the timing for the colonoscopy or endoscopy. 9 to 14 hours is direct oral anticoagulants. And you also have to keep in mind the creatinine clearance, because dabigatran, the elimination time can go up to 18 to 24 hours with creatinine clearance of less than 50. Then comes the vitamin K antagonists. They have a very long half-life, 36 to 42 hours for warfarin, and even longer for phenproquine. human. So we talked about a half-life. So this half-life is used to figure out when do you stop the medication prior to the procedure. We'll go in detail about the days before the procedure when you stop the treatment. Now let us talk about peak action to figure out when to restart the medication. You have three groups. As you can see on the left, rapid peak for direct oral anticoagulants, 2 to 4 hours, and low molecular weight heparin, 3 to 4 hours. So for low molecular weight heparin, it's a half-life and direct, and then peak action is 3 to 4 hours. Then comes variable peak with ultra unfractionated heparin, 4 to 24 hours, and then very delayed peak plateau, that is vitamin K antagonists. So we talked about elimination half-life, peak action, but you also have to keep in mind renal clearance as an additional factor to be considered. Among all the anticoagulants, uh, there are a couple of drugs that do not depend on very minimal dependence on renal clearance. These include unfractionated heparin and vitamin K antagonists. So these are the drugs that are favored in patients who have renal insufficiency. Moderate bypass, apixaban, and rivaroxaban. High risk of getting into trouble in renal failure, low molecular weight heparin, dabigatran, and edoxaban. So keep this thing in mind that two extremes, unfractionated heparin and vitamin K antagonists, can work even with renal failure, but that becomes a problem for low molecular weight heparin, dabigatran, and edoxaban. So with these principles of elimination half-time, peak action, and dependence on kidney for clearance, we'll talk about how do we use DOACs in the perioperative period. So you have four main groups of drugs, four drugs in DOACs: apixaban, dabigatran, edoxaban, and rivaroxaban. And when you're thinking about this, you have to think about two things. One is obviously, is the kidney function good or poor? Look at the creatinine clearance. Number two, what type of procedure are you performing? If you are performing a low-risk procedure versus a high-risk procedure. Why is that important? If it is a high-risk procedure, you want to make sure that you have allowed enough clearance of the drug so that there is no residual effect. On the other hand, if it is a low-risk procedure, you should be able to still do the procedure with a little bit of drug still in the system. So for low to moderate bleeding risk procedures, like any endoscopy with some biopsies, all you need to do is stop the DOAC 1 day prior to the procedure. And this applies to apixaban, edoxaban, rivaroxaban, and dabigatran, as long as the creatinine clearance is more than 50 ml per minute. That changes in patients undergoing high bleeding risk procedures like polypectomy, EMR, ESD, sphincterotomy, and peg placement, stricture dilations, etc. In these patients, you stop DOACs for 2 days prior to surgery. So prior to surgery, day 0 is surgery. So you stop, say for example, procedure is scheduled this Friday. So it's a high risk EMR. So you tell the patient to don't take the medication on Thursday and Wednesday. Their last medication should be taken on Tuesday. So you have 2 days of medication. I want you to keep in mind whenever you have a patient on dabigatran, before you do anything, check the creatinine clearance. If the creatinine clearance is less than 50, you may have to dose that patient different. In this case, with the dabigatran, with a creatinine clearance less than 50, you have to increase the number of days of treatment. For low-risk procedures and low to moderate risk procedures, at least 2 days. For high-risk procedures, you even go even further, 4 days before the procedure. All these patients who undergo procedures on DOACs, make sure that they do not take the DOAC on the day of the procedure, that is day 0. So this is something to keep in mind. So how do I tell my patients who are coming in for colonoscopy, especially screening procedure, and you don't know whether you'll find polyps and you may need to do resection. And if that's the case, uh, I tell my patients to hold off their DOACs, the apixaban, rivaroxaban, edoxaban, and dabigatran with a creatinine clearance of more than 50. If the procedure is scheduled Friday, say on the day of the procedure, Friday, don't take medication, and then you don't take the medication for 2 days before, that is Thursday and Wednesday. They can take their medication on Tuesday. So it gives them 2 days so that if in case you need to do a polypectomy, you can safely do that procedure. Say, for example, your procedure went well and uh, you don't expect major bleeding risk because you did just a small polyp resections with either cold biopsy polypectomy or a cold snare, then you could resume the DOAC 24 hours post-procedure. It said 1 day, but I say 24 hours. Say, for example, my procedure is done at 4 o'clock today. I tell the patient, don't take it, it's not 1 day tomorrow. I ask them to take it tomorrow evening. That gives them 24 hours if they are on a BID dose. If not, they take it the following day. Uh, 1.5 days later. On the other hand, if you have done a large polypectomy or an EMR or an ESD, then you want to wait at least 48 to 72 hours before you resume the DOACs. Because these patients are at high risk for bleeding, and starting a DOAC, given that they have peak action within a few hours, these patients are at high risk for bleeding. You have to keep that in mind, the peak action time of DOACs of just 3 to 4 hours in mind, so that you can tell the patient, hey, the moment you take the medication, your blood will be thin, so you keep that thing in mind before taking the medication, uh, and tell them exactly when to take the medication. In some high risk for thromboembolic risk patients, you could consider low dose anticoagulants like enoxaparin or deltaparin to prevent that thrombotic risk. So let me summarize about pre-procedure interruption. Low to moderate risk interruption for standard DOACs with that includes all the apixaban, edoxaban, rivaroxaban, and dabigatran with a creatinine clearance of more than 50 for low risk, moderate risk, 1 day off, high risk, 2 days off. And when it comes to dabigatran with a creatinine clearance less than 50, for low risk also, you stop 2 days before, for high risk, 4 days before. So this table is very important to keep in mind. And coming to when do you restart after this procedure? For low risk, for DOACs, you could restart 1 day later. And for high risk bleeding risk procedure patients, 2 to 3 days later. But if the patient has also high risk for thromboembolism, like the patient with cage valve or mitral valve disease with atrial fibrillation or a DVT within the last 3 months, those are all very high risk. In that case, you may want to consider low dose, low molecular weight heparin as a bridge. So now let us move to management with warfarin. In terms of warfarin, if you are planning to do a procedure without bleeding, without diagnostic procedure, without resection of any polyps, minimal bleeding risk, you can continue warfarin and do your diagnostic procedure as long as you're gentle. For moderate bleeding risk patients, you pause the warfarin. You don't have to give low molecular weight bridging during that period. And those with high bleeding risk and also high thrombotic risk, you may have to consider some type of bridging. So let us look at it. So here is warfarin in a patient who is undergoing just diagnostic procedure without biopsies. The patient can continue warfarin without interruption. On the other hand, if you're planning like a polypectomy or EMR, you tell the patient to take their warfarin until the last dose of warfarin should be on day -6 and no warfarin for 5 days. And then you do the procedure, and after the procedure, on that day, you can start warfarin. Stopping warfarin 5 days before is because of the very long elimination half-life. And restarting warfarin on the day of the procedure is a very delayed peak effect. So in both ways, this information is useful, knowing the half-life and knowing the peak action of warfarin. There are some patients who are high risk for bleeding and also high risk for thrombosis if you interrupt the medication. In those cases, when you stop your warfarin and before you restart your warfarin, that period you try to cut down the risk of bleeding, but you are afraid of thrombotic risk. In those patients, you may have to consider some type of bridging with low molecular weight heparin that has a very short half-life and a very short peak action, so that you could use this principle to manage that period when they're at high risk for thrombosis and high risk for bleeding when you interrupt warfarin. So let us see how it works out. So here is a patient who has, say for example, high risk for arterial thromboembolic risk. You know, we looked at that in the last lecture. Say for example, a patient with a mitral mechanical valve with atrial fibrillation, heart failure, etc. That patient is very high risk for thromboembolic event. more than 10% per month. So in that patient, you stop the warfarin, last dose day minus 6, and no warfarin for 5 days. And then day minus 3, day minus 2, and day minus 1, you cover that patient with subcutaneous low molecular weight heparin with standard dose for 2 doses, and then the day before you use half the total dose. And that way you still protect the patient from thromboembolic events, but also be able to clear the low molecular weight heparin completely, so that a high-risk procedure can also be done. Once you finish the procedure and then you want to restart your warfarin, you could restart the warfarin in these patients on the day of the procedure or the following day. And then, because warfarin takes a long time to reach its peak activity, at least several days, and during that period, you could consider using low molecular weight heparin for the first couple of days for venous thromboembolism prophylaxis. That's a small dose, and then full dose on day 2 or 3. And you continue the low molecular weight heparin until warfarin reaches therapeutic INR levels. So we've learned a lot of things. Let me review this further. So when you plan to do full dose bridging, when you hold off warfarin, you could use enoxaparin 1 milligram per kg twice a day, or 1.5 milligrams per kg daily. But in the early post-op period, you may want to give just a small dose of 40 milligrams daily. For deltaparin, pre-op, you could use, and late post-op, 100 units per kg twice a day, or 200 units per kg daily. And in the early post-op period, you want to still play safe to prevent a thromboembolic event, but play safe against bleeding. You could consider a low dose of 5,000 units daily. So let us put these things together. In a patient who has minimal bleeding risk, you could continue warfarin. That is simple diagnostic exams without biopsies, etc. For low to moderate risk, like somebody undergoing a colonoscopy or endoscopy where you just plan to do biopsies but not polypectomies, then you ask the patient to stop warfarin 5 days before. The last dose for warfarin will be day minus 6, and then 5 days of no warfarin. And after the procedure, on the day of the procedure, you can ask the patient to start warfarin. In patients who are high bleeding risk, then you do the same thing, stop warfarin 5 days before and restart warfarin on the day of the procedure. But if they are at high risk for thromboembolic events, you should consider bridging day minus 3, day minus 2, day minus 1, day minus 3, day minus 2 standard dose of low molecular weight heparin, and day minus 1 you give half the dose. If the patient is, after the procedure, you worry that there is a high bleeding risk, then you don't start the standard dose. You delay the standard dose to day 3 or day 4, and in between you cover them with venous thromboembolism prevention dose, a small dose. So we covered a lot of material. Now let us switch to antiplatelets. And these include aspirin, that is the foundation for antithrombosis in arterial disease. Then P2Y12 inhibitors, clopidogrel, prasugrel, ticagrelor, cangrelor, and then various nonsteroidals that are used for different vascular diseases. It's important to understand the mechanism of action. We know that aspirin, clopidogrel, prasugrel, they once you take the medication, they permanently disable the platelet. So that means for the new platelets to form, and the lifespan of that platelet is 10 days, so you don't have any effect. That platelet effect is gone for 10 days until the new set of platelets come. On the other hand, medications like ticagrelor, cilostazol, dipyridamole, pentoxifylline, they cause only temporary reversible inhibition. And once the drug is cleared from the stream, the action on the platelet in terms of inhibition of the platelet is gone. So this is something to keep in mind when you're planning your treatment. Then, in terms of the peak action, as you can see, cangrelor has very fast, 3 to 6 minutes. Then comes aspirin, 0.3 hours, that is about 20 minutes. Ticagrelor, 2 hours. Clopidogrel, prasugrel, 6 to 7 hours. This is important to keep in mind again, because when you plan to restart treatment, you want to keep these things in mind when you're planning to restart, because the peak action is pretty fast for ticagrelor compared to clopidogrel. And now come to elimination half-life. As you can see, these are all numbers that you may not need much, but just for the sake of completion, I put it in here. So with this background, let's talk about perioperative antiplatelet management. We know that patients who are on secondary prophylaxis using aspirin, not primary prophylaxis, secondary prophylaxis as an indication for aspirin, you should continue that aspirin for various endoscopy procedures. On the other hand, if the patient is taking aspirin to prevent a cardiovascular event without any prior history, in those patients, if you could consider to hold them, because the benefits, we know that the risks outweigh the benefits in primary prevention. When it comes to prasugrel, it is about 7 to 10 days before the procedure, you hold the medication. Clopidogrel, 5 days before the procedure. Ticagrelor, 3 days, 3 to 4 days, 3 to 5 days before the procedure. You hold before you undertake any procedure. After the procedure, you could restart them 1 day later, and in certain high-risk procedures for thrombotic events, you could consider very fast-acting antithrombotic medication, that is cangrelor, because of its very short half-life and very fast peak action. This is a medication that cardiologists use. This is not what we use in our practice. For most of us, we probably don't end up dealing with that unless you have to manage a patient with a GI bleed in somebody who had a coronary stent that was placed within the last few days. And the cardiologist is worried about thrombotic event, and you're worried about bleeding event, and in that situation, maybe this is something that would be helpful. A lot of information covered. I hope this is helpful. Thank you.